All right. You guys got so quiet. Anybody have any questions before we get rocking and rolling on this stuff? Anybody have any questions as we prepare for Friday and get out of the way? You know, crystal clear. Everything is crystal clear. The exam is ready to download. She's gotten a reminder. So it is set. The modified course objectives that I gave you were just to give you a little bit more specific objectives. When I look back over the course objectives, when that was like your study guide, I realized they were fairly vague. So so I did tweak those a little bit so that they're in, more in line with what's on the exam. So if you have any questions about any of those, let me know. I am going to pass around little slips, or you can come up and get one on break. If you have any questions from this lecture or questions as we go forward on to Friday, that would be lovely. All right. So seeing no questions, we're going to just do a couple of did you get it questions for review. So from the spine section, which direction does the right superior facet slide? Let me make sure I don't know if I got any recording. Hold on a second. That would not be good. And I do apologize. Oh, pause recording. Okay. The last lecture, when we came back from break, I forgot to hit the record button. So there was a gap in the information from the recording. And somebody told me the slides don't advance on the recording.
Yes, 2 videos where like half of it's just the same slide.
And I do not know. I'm doing Zoom, so I don't know what I'm doing wrong there. So I don't know what to fix there yet. Maybe I'll try Screencast-O-Matic next time instead of Zoom, but we'll just go with it for now. And I can say out loud, I'm changing slides, if that would help, right? Because you guys should all have those slides. Okay, so in which direction does the right superior facet slide during right side flexion? So when we talk about the arthrokinematics of the spine, we're going to refer to the superior segment moving on the inferior segment. I will never ask you, what is the inferior segment doing during arthrokinematics? So don't let that bog you down. I'm always talking about what the superior one is doing. So when you go into right side flexion, is it moving superiorly or inferiorly? Inferiorly. Yep, the ipsilateral one slides down, the contralateral one slides then in which direction? So which direction is the left superior facet slide during right side flexion? Superiorly, right. So this is your basic arthrokinematics. If you get this about the spine, manual therapy is going to be oh so much easier for you. So it looks like the ipsilateral side is doing the same thing that it would do in extension because they slide inferiorly. The contralateral side looks like it's doing the same thing that you would be doing in flexion, sliding superiorly. So side flexion is kind of extension on one side, flexion on the other. That makes sense? Because it's the same arthrokinematic. It's just a plane, just sliding. All right, so what muscle activation do the following muscles contribute to the movement? So if you're raising a glass to your mouth, what is the bicep doing? Concentric, eccentric? Concentric, what's the tricep doing? Going along for the ride, potentially. Let me go on to this slide so I can. Does anybody disagree with that? So triceps just kind of hanging out. So let's say you're bending your legs to sit in a chair, and we're talking about your quads. So as you go to sit down in a chair, are your quads concentric or eccentric? The majority of the quads. Let's talk about where they are at the knee, because that's a little more direct. Are they lengthening or shortening with that motion? Lengthening, and is it under tension? Yes, so that is eccentric. So landing from a jump, we did this in lab. So landing from a jump, quads and glutes. So as you contact the ground, what are your quads doing? Lengthening or shortening? Lengthening. What are your glutes doing? Lengthening, under tension, so eccentric, right? These are easy, right? Looking at your feet from a standing position. So somebody says, Kathy, did you realize you have 2 different shoes on today? And I went, really? What are my cervical muscles doing in the back of my neck? As I go, oh, that's not good. I'm glad Ben's not here to tease me.
They're eccentric.
Eccentric, right? You're lengthening. Your cervical extensor muscles are lengthening under tension, the weight of the head. If they said, Kathy, there's a tarantula moving towards your shoe, and I go, what? Then it is concentric flexors, and the eccentric one, or the extensors, really don't even know what hit them, right? So think about, are they under tension, are they lengthening or shortening? Okay, so that should be fairly direct. Oh, here, pounding a nail with a hammer. What's the bicep doing? Let's go with tricep, that's easier. Boom, pounding a nail. Concentric tricep. The bicep likely is eccentrically controlling the movement at the end so you don't break your olecranon. All right, so the bicep is going to slow that down right at the end. Okay, if you have trouble with those, then look into that a little bit more, but those should have come to you fairly quickly. So we're going to look today, a little kind of a very brief review of the shoulder articulations because it matters to us when we talk about the movement. And then we're also going to look at the arthrokinematics because we can't live without arthrokinematics in our kinesiology world that we live in. The scapulothoracic rhythm, the dynamic stabilization of the scapula is it's kind of like how the body does the spring load with the jump, right? It's just amazing how the body coordinates, and you don't even have to think about it, all of the muscles around your scapula to get your arm where you need it. So of course, it's a complicated process because nothing in kinesiology is very simple. And then we're going to look at the key muscles and what they do. So the shoulder articulations, there are 4 shoulder articulations in the shoulder complex itself. Only one attaches the scapula and the arm to the axial skeleton, right? I know you talked about this in anatomy. The AC joint, the sternoclavicular joint, the SC joint, is the only attachment of the whole shoulder complex to the axial skeleton. There's a lot that goes on there that you wouldn't suspect. The acromioclavicular joint is the attachment of the scapula basically to the trunk, the body. And those 2 joints work together synergistically to get the scapula where it needs to be. The sternoclavicular joint, we're going to look at the arthrokinematics. It's a saddle joint. So there's a portion of that joint that is going to move, that is going to arthrokinematically be convex on concave. And of course, there's a portion that's going to be concave on convex. So that makes it a little more challenging. And when you go to mobilize that joint for manual therapy, that's really important to know which way to mobilize. We're going to figure that out. The scapulothoracic joint is really not a true physiological joint, right? It's not like a synovial joint or something like that. It's just the movement of the scapula on the thorax. We call it an articulation, really not a joint. And then the glenohumeral joint, obviously. These, all these articulations together give us the opportunity to raise our arm all the way up over our head. If we're missing one of these even, or if one of them isn't very functional, we lose the ability to raise our arm over our head. The glenohumeral joint provides probably 2/3 of it. It's the more mobile of the joints, obviously. It's the most mobile joint in the body. And about 1/3 of it comes from the scapulothoracic movement. So the movement of the scapula on the thorax. That AC joint is important because it actually transmits forces and things from the arm to be absorbed by the axial trunk. So it's important. It actually has 3 degrees of movement that we're going to talk about. Its primary job is to kind of fine tune where that scapula is in relation to the arm. It is well surrounded by by muscles. The deltoid and traps surround the acromioclavicular joint. So it's got a lot of muscle support. The plane of the scapula, it doesn't sit just in the frontal plane. It sits on the thorax at the side. So it actually has a bit of an angle, about 30 to 35 degrees from the frontal plane. So when I'm working with somebody and I want to work on shoulder abduction, or if I'm teaching them to do an exercise to strengthen their supraspinatus, I'm going to have them work in what we call scaption, right? So it's not abduction, it's not flexion, it's scaption. So I'm having them actually abduct in the plane of the scapula. That avoids impingement. If you're in the frontal plane, this is really uncomfortable to abduct your arm clear back here on the frontal plane. So that scaption position is important to avoid impingement and dysfunction at the shoulder. Primarily the glenohumeral joint. So the sternoclavicular joint. I have a lot of crepitus in my sternoclavicular joint. Who knew it was such an important joint, right? It just kind of sits there. Nobody really pays much attention to it. But it really is what helps to fine tune where the scapula can be. So the clavicle does elevate and depress. So from its position on the manubrium, the distal portion or the lateral portion is going to elevate or depress. That happens to be the convex on concave aspect of the clavicle. So it's going to be roll and glide opposite. So as you elevate, the distal end of the clavicle goes up, so the proximal end is going to go down. So that's the opposite motion. The protraction, retraction happens in when you protract and retract your scapula. We call the clavicle protraction, retraction as well. This is the concave on convex aspect. So as you protract anteriorly, you're going to glide anteriorly at the AC joint. And then the other degree of freedom is spin. And it just spins along the longitudinal axis of the clavicle. So to help you kind of remember the saddle joint position and the movements, you can take your hand, your left hand, and put it where your manubrium would be. So in the direction of your manubrium. So you've got this concave surface, and then you've got this convex surface. And you take your other hand, and this is your clavicle. All right. So now when you elevate, the convex surface is moving on the concave. When you protract, retract, the concave surface is moving on the convex. That works for some people. For other people, they go, I have no idea what you're talking about. All right, so we'll look at it a little bit in lab, but that's one way you can try to remember that position. And you're gonna, it comes into play because we do mobilize the clavicle, so you've got to know which direction it moves in. The costoclavicular ligament is that ligament right here, the CCL. And that really is an important ligament. It pretty much anchors that end of the clavicle and gives it its origin for those movements. So it's an important ligament. It's stretched pretty much in all directions except for depression. It gets slack in depression. The AC joint is a planar joint. So we're going to say it's a flat surface on a flat surface, which is lovely, because then we don't have to care about all that other minute detail. And the motion that occurs at the AC joint, again, is 3 degrees of freedom. Upward rotation and downward rotation. When we talk about these, we kind of talk about where the glenoid is. Where is where's the humerus sitting? So where's the glenoid? So I brought visual aids. I'm not exactly sure how they're going to work, but we'll give it a go, right? So this is the clavicle, right? And it's inserting here at the AC joint. So this is the medial border of the scapula, right? So upward rotation of the scapula is that motion, right? So the glenoid is facing upward. Downward rotation is here. Is this all review? Am I belaboring this point too much? Internal, external rotation is going to be, again, here's the AC joint. Internal, external rotation is going to be in this plane, right? So I always do this one wrong. Internal rotation is this direction. External rotation is that direction. I always have to think about this one. So if you think about the glenoid, internal rotation, you're rotating it inward. External rotation, you're rotating it externally. Internal, external rotation. And then tipping, you've got motion in this plane. So you've got posterior tipping and anterior tipping. The reason the scapula has to move like that is it needs to stay in contact with the thorax as it moves through its motion. So it needs to be able to tip forward and back. Posterior tipping when we abduct. It's an anterior tipping when we protract. So all those motions need to occur at the AC joint. So then we look at the scapulothoracic joint motions. And these are similar names, but they have different meanings. Isn't that confusing? So if we talk about elevation and depression, you just think about the scapula moving in elevation and depression. That is elevation, depression. The medial border doesn't change, right? Protraction, retraction. So you're protracting this way, you're retracting this way, right? And then upward and downward rotation again is in reference to the glenoid. The problem is the scapula is connected to the clavicle. So in order for the scapula to just elevate, two things have to happen. The SC joint has to elevate, but there has to be a downward rotation at the AC joint, right? This is always a complicated, for some reason, this is always very complicated for people. So Mallory tells me it might be, right? So elevation of the scapula requires elevation of the SC joint, downward rotation at the AC joint. Protraction and retraction. So as you protract, your SC joint protracts, but there is an external rotation at the SC joint. And then for upward and downward rotation to occur, obviously you're going to elevate at the SC joint, and you're also going to have upward rotation at the AC joint. So you have to think about where you want the medial border of the scapula. Do you want it upwardly rotated like that, or do you want that medial border to stay vertical? So you shrug your shoulders, right? And that is an elevation. You abduct your arm, and that's when you're doing the upward rotation. Why is this important, you ask? Why am I putting you through this? If you have a limitation in upward rotation of the scapula, there's a whole lot of factors to go into consideration. And if someone has adhesions or scar tissue or damage at the AC joint, that may be where it's happening, and that might be the joint that you need to address. It could be happening at the SC joint, so that might be the joint that you need to address. So you need to be able to appreciate the quality of the movement so that you can identify where the loss is. Make sense? All right, let's move on to something that's more easy. Let's talk about the glenohumeral joint. And stabilizing tissue, this is all review. So if this is not review for you, you might want to dig your books back out. The labrum extends the joint even more so than in the hip, right? Because there's a labrum in the hip. The glenoid labrum increases the joint congruency by about 50%. There's very little bone-on-bone contact between the head of the humerus and the glenoid. The rotator cuff muscles do a fairly good job of surrounding the head of the humerus. They don't completely. We're going to look at some of the areas where there's a weakness. But they dynamically then stabilize. They are not passive components. The rotator cuff muscles dynamically work to keep the head of the humerus where we want it in the joint to avoid impingements and subluxation and things like that. They have attachments to the capsule, so they're very intimately related to the joint capsule itself. Another important stabilizer is the biceps long head tendon. It slides right up over the top of the bicep and inserts there at the capsule. And it really gives some anterior stability to the shoulder. And then obviously the glenohumeral ligaments, although the ligaments themselves, superior, middle, and inferior, the inferior one is very lax. So there's not much restraint from the ligaments for abduction. The joint capsule itself, because you've got all this motion, right? You've got this head of this humerus sitting on this little piece of bone surrounded by soft tissue and muscle. And the capsule has to be able to adapt to internal rotation, external rotation, abduction, flexion, right? So you've got about twice the volume in the capsule as the bony parts, the head of the humerus. So the joint capsule itself is roomy, very roomy for the head of the humerus. The arrangement of all these tissues is really crucial as well to the motion and the control. That pesky little coracoacromial arch is probably what causes us the biggest difficulty, because all these structures pass underneath that bony area. And all of them can be subject to impingement if we don't move our head of our humerus right? If your head of your humerus is really sloppy when you go to move, it can ride too superiorly and pinch that stuff. And that's when somebody gets an impingement. The other thing that can happen is some hypertrophic growth at the acromioclavicular joint from use and abuse and that sort of thing. So it can crowd that space as well. So the supraspinatus is the rotator cuff muscle that's usually the one involved in impingement, because it's just right underneath that, right? It's right there. And it helps to abduct the arm, helps to bring that arm up against gravity with the deltoid. The other rotator cuff muscles pretty much surround the head of the humerus, but there's a gap in them between anteriorly and also inferiorly. And those anterior dislocations, anybody ever dislocated their shoulder? Yeah. This motion is typically the motion that causes the head of the humerus to kind of roll out of the joint. And because there's not a real good dynamic component in the front at that point, right? Your biceps tendon is now rolled backwards. You have a pretty easy shot at dislocating your head of your humerus. That's typically the motion that occurs. You can see how small you guys have dissected in anatomy, so you know how small that bony attachment is there. And then the ligaments are also shown there. So the superior glenohumeral ligament, middle glenohumeral ligament, and then the inferior one is like a kind of like a pouch. Right? It doesn't do much but keep the synovial fluid in the joint. One of my pet peeves, I'm going to get on a soapbox right about now. I work with the older adult population, and for some reason, people who help or work with people with older adults think that the arms are designed as levers to help with transfers, right? You grab their arm, you haul them out of their chair. You're talking about a shoulder joint that has atrophied muscles, ligaments that are not as pliable as they used to be, and very little bone-to-bone contact. So these folks end up with rotator cuff tears, surprise, surprise, because people are lifting their 120 to 180 pound body weight or more on that itty bitty little joint there. So pet peeve, right? I mean, I have educated CNA and nurse and OT and PTAs and PTs about not using the arm as a lever. It is not a transfer device. So if you learn anything from this lecture, that's your takeaway. I should put that as, I don't have a question on the exam for that, but I should. All right, so the static stability, the glenoid faces like this, right? It faces upward. So the head of the humerus kind of just sits there on it. That's assuming the scapula is in the right place. Assuming the scapula is being supported well by the upper traps and the whole trapezius. So in that position, gravity is kind of pulling down on the arm, so it's helping it to sit on that glenoid inside the labrum. The superior capsule is a little bit tense at that point, so it's helping to kind of hold things in. The ligament that runs from the coracoid process to the humerus, the coracohumeral ligament, big honking ligament, it's doing a good job of helping with that as well. And then the supraspinatus, it says passive tension. If you're just standing there statically, the supraspinatus is just providing a little bit of muscle, just that passive tension. It's not actively firing typically. But there is a tone that's there. Because if you work with somebody who's had a stroke and they no longer have the muscle activation in their shoulders, they sublux. And you're going to learn this in neuro, right? You can actually see the head of the humerus has sunk down, and you can measure a centimeter or 2 centimeters between where the head of the humerus should be sitting and where it is sitting. So there's this dip. And that's because the control of the scapula maybe has tipped and the supraspinatus isn't providing that passive tension anymore. It causes a lot of pain for those folks. So with the pull from the superior segments, kind of towards the upper part of the shoulder, and then gravity pulling down, you have this resultant force. This is actually the force that's pulling the head of the humerus into the glenoid. So that's static stability. That's just standing there in line waiting to pay for your groceries, right? So then we have dynamic stability, right? That's where things get really important, when everybody plays nice with each other. And you think about that major honking deltoid up there, right? You got this deltoid that's coming all the way around from the scapula to the clavicle. Big old honking muscle coming down, holding the humerus up in place. And as you begin to move and elevate your arm, the deltoid pulls the head of the humerus superiorly, right up towards that acromioclavicular arch. Squeezing all those structures in there, right? So that superior pull of the deltoid has to be counteracted by something, or we would all run around with impingements. So the supraspinatus helps because it compresses, it pulls the head of the humerus into the glenoid. So as you rotate, it is keeping the head of the humerus pulled into the joint as the deltoid pulls up. And the heroes of the day are our rotator cuff muscles, the other three. Because their line of pull, remember where they're attached, right? They're in the capsule, and their subscap is pulling in this direction. Infraspinatus is pulling in that direction. Teres minor is pulling in that direction. Their line of pull is inferior, medial and inferior, because what they're trying to do is counteract that deltoid. Big little honking deltoid up there, trying to pull that arm up and jam it up into the coracoacromial arch. So it's really important for those rotator cuff muscles to activate during dynamic movements of the shoulder, or you have impingement problems. So if you have somebody with an impingement problem, one of the first things you're going to look at is their control of their rotator cuff. So do they have loss of strength? Do they have a tear or damage? Or do they just have poor motor control where it's not activating before the deltoid has a chance to jam things up? Oh, look at that. I got little arrows. Always forget when I add these things. Okay. So here's that scapular posture and that static stability. And so see how that head of that humerus kind of hangs on the glenoid. So it's nice that it's directed upward. It's nice that the supraspinatus is holding things, kind of compressing things up and in. If that upward rotation is lost, then the compressive force actually changes its line of pull and the head of the humerus slides down. And that's what happens with stroke patients who've lost functional control. I don't know if I've talked to you guys about this, but I had a couple of benign carotid body tumors in my neck. When they went in to surgically remove those, they pretty much wiped out my last 4 or 5 cranial nerves, one of those being the accessory nerve. I never knew how much I appreciated my accessory nerve until I didn't have it. The hypoglossal too, but we won't go there. So I went to, first time I got up in the hospital, I went to brush my teeth. I said, oh my gosh, it feels so good. Brush my teeth. So I was doing this, right? And I always like scoop water up, bring it up to my mouth. I'm doing this and I went, oh, this is not good. I cannot get my hand to my mouth because this whole scapula, my trap was shot, right? I had no trap. When I was getting ready to leave, I put my bra on, strap went boom, right? Because my whole scapula was downwardly rotated. I couldn't do abduction, the whole deal. So orientation of that scapula is so important for function of this arm, right? You've got to have the scapula stabilized and in the right position to do functional tasks. Never hit home as much as when I couldn't bring water to my mouth. I didn't even notice it until then. Honestly, I didn't even know that was a problem. The tongue thing I knew. A doctor came in. Of course, I knew enough about cranial nerves. And this was, I don't know, 10 years ago, something like that. So the doctor came in. He's like, so how are things going? Oh, let me show you. First of all, I didn't have a voice because I lost one of my vocal cords, paralyzed. But I went, look. He's like, I said, yep, I'm not doing that on purpose. So I had no control. Couldn't, it was interesting. Okay, enough about me. So yeah, so it's very important to maintain that upward rotation. So just kind of a wrap up, scapulothoracic stability, the ultimate functions of scapular motion. Why do we have scapular motion? Why don't we just attach the glenoid on the end of the clavicle? Wouldn't that make more sense? It'd be simpler. We wouldn't have to deal with the clavicle or the scapula and all it does. But without it, we wouldn't be able to orient the glenoid fossa for proper positioning. Think how hard it would be to throw a baseball if you didn't have your scapula. It adds range of motion as you elevate your arm. You got about 120 degrees in your glenohumeral joint. We want to get up to 180, so that 60 degrees comes from upward rotation of the scapula. We also want to be able to stabilize our glenoid. We don't always want the scapula for movement. We need it for stabilization. So imagine if we couldn't stabilize our scapula doing a push-up or doing a pull-up, right? Or even throwing a ball, right? You toss a ball and nothing is stabilizing your scapula, that ball's all over the place. So very important. All right, so just a flashback question. You're working with a patient with limited shoulder motion due to a capsular restriction. What direction do you need to glide the humeral head to improve abduction, abduction? You want to get them up here, they're restricted. Which way do I need to glide this joint to get them more motion this way? Superior or inferior? Inferiorly, right? You've got a convex and a concave. My arm is moving superiorly, so the opposite motion occurs at the proximal end, so that is inferior. Right, perfect. How about for external rotation? So I can't externally rotate my arm. It's easier if you bend your elbow for these, because then you got some direction to go with, right? So we're still talking convex and concave. I'm rotating, my hand's going, let's call it posteriorly. So what direction would you need to mobilize for external rotation? Anteriorly, right? Oh, here's another one. Oh. Wait a minute, I gotta get to where my questions are. Okay. When raising your arm overhead to reach a high shelf, what motion needs to occur at the sternoclavicular joint? So this joint right here, what motion is occurring at the clavicle as you reach your arm overhead, right? So we're going to reach up this way. In this plane, your choices are elevation or depression, right? So we are elevating the clavicle. If this works for you, go for it. So as you elevate at the joint itself, you need to move the clavicle inferiorly, right? Because with elevation, this end's going superiorly. So you need to drop it inferiorly. Move it inferiorly. Oh, got ahead of myself. Okay, so what associated adjustment has to occur at the AC joint? So this time we want to reach to a high shelf. So we want our arm up overhead. We want that clavicle or the scapula to upwardly rotate, to orient our shoulder, our arm up above. And what position is the scapula in for this motion? Upward rotation. Right, that's not so hard. thought you had a question, Wayne.
Quick question.
Yes.
It says elevation, wouldn't it be depression?
The motion that's occurring at the sternoclavicular joint is elevation.
So you're not talking about the inferior thigh?
If I were to move it, I got ahead of myself. If I were to move it, the motion that's occurring there is inferior thigh. Yeah. I thought that question was in there and I took it out.
This is like more like big picture, like if you're looking at the.
Right, yeah,
here.
yeah, so we're looking at the orientation of the scapula and, or the scapula and the clavicle with the sternoclavicular and AC joints. If I didn't want to reach overhead, if I just want to go, I don't know, then the associated motion at the AC joint would be a downward rotation. That's your difference. Same things happen at the clavicle or the SC joint. Does that make sense? I don't need to explain that again. Okay. All right, so let's talk about some muscles as groups and their jobs. And again, these should make good sense to you, but all I want to do is kind of reorganize the muscles so that we think about them for movement. So the elevators, the primary elevators of the scapula are upper trap, levator scapula, and rhomboids. And you can see their line of pull there. If they all activate with no help from anybody else, though, what other motion are you going to see occur at the scapula? Downward rotation. They're all oriented on the medial aspect. So if nothing else helps out, you're going to see downward rotation. And the levator scap and upper trap are two, well, and the rhomboids too, for that matter, are really common spots for trigger points. You know, people come in, I know I felt a few on you guys in lab. You got those real hot spots up here from your neck into your shoulder. Typically, I think levator is the most guilty because of the forward head posture. It puts extra stress on it, but they are holding that scapula up all the time. There's a lot of slow twitch fibers in these guys because they've got to stay functioning just in sitting posture. So if you have pathology of these muscles, a weakness or a paralysis, or you lost your accessory nerve, right? Some of those other things, gravity is going to pull your scapula in a depressed, protracted, and downwardly rotated position. The downwardly rotated part is primarily because of the weight of the arm, because there's nothing counteracting the weight of the arm. And that boogers up everything you want to do with your arm. I've got some videos, hopefully they will play, of weakness in the traps as opposed to the serratus. And it's pretty dramatic. I wish I'd taken video of myself doing my rehab, because I had to work back through some, my nerve woke up again. They were just traumatized. So from the surgery, so I actually did regain my cranial nerves, all but my vocal cords. So, I mean, that's good news. That, and I also have a Horner syndrome, which is loss of the sympathetic system on the side of the face that's affected. So I have, when I exercise really hard, you know, the sympathetic system helps you with your fight or flight. So when I exercise really hard, the left half of my face is white and the right side of my face is a line right down my forehead, red, because of the exertion. What's really funny is, so I don't sweat much on this side until I eat spicy food. And then I sweat right underneath my left eye, but nowhere else. I don't know, it's the weirdest thing. So that's a Horner syndrome. And it does affect the sympathetic system. So you might see that in some of your patients. Okay, so let's talk about depressors, muscle, not exams coming up and other things that might depress you, but let's talk about the muscle depressors in the shoulder. Line of pull, obviously pulling that scapula down. So we're talking about lower traps, latissimus dorsi, pec minor. We kind of forget about pec minor, but it's a really important one in the front. We have a lot of pathology with that one from forward shoulder, forward head position. That gets really tight and angry. And the subclavius, sneaky little guy, is mainly just providing compression at the SC joint. It doesn't really work as a for motor function. Its primary job is a shunt muscle, so it's just kind of helping the clavicle be pretty stable on the maneuvering, because it's it's not a very well supported joint. It's got a strong capsule around it, capsular ligaments and stuff, but there's not much bony congruency, so that helps to have the subclavius kick in. So your depressors can depress your scapula, but if you are exercising and you want to use your lat, so this is a lat exercise, right? Primarily lat dorsi, so you're pulling down and squeezing those scapula together, but you also can do ones where you're pushing down this way, right, and lifting your body up. So depending on if you fix the origin or fix the insertion, you can actually get some butt lift off a chair with your scapular depressors. That's actually a really good way that we exercise the older adult population to work on muscles that they use to push down on a walker, right? So they need a pretty good lat dorsi and lower trap and that sort of thing to help them depress that scapula and use the walker and get good support from it. The protractors, this is good old serratus. We love serratus. It makes our scapula not stick out the back so people make fun of us. It's a no judgment zone in lab when we do this on Monday. It is a very strong protector of the scapulothoracic joint. It holds that scapula against the thorax, right? That is its job. As it moves through functional motion, as the scapula moves to upward and downward rotation, the serratus is holding that scapula against the thorax. I don't know if you can tell from this picture, but the green dot is the axis of motion at the AC joint, right? Where it wants to do internal, external rotation. The serratus is on the inside of that axis against the thorax. So it really has a good line of pull to hold a medial border against the trunk. Nice line of pull. You can see the serratus on, when they have superheroes posing, right? You can see that serratus activation along the trunk. So somebody who's done a lot of that physical activity. Ben's son Kyle is the one that did the javelin. Remember the javelin video that we used? He's also the one that does your video, most of the videos for the practical, so you all see him again. But he has some for a 15-year-old. I think Ben must be down there like, I can say this because Ben's not here. He must be down there like cracking the whip on that poor 15-year-old kid. Because I mean, he's got some really good muscle development for a 15-year-old. So anyway, yeah, I would say that even if Ben was here. Okay. And then the retractors. Yeah, let's do this and then we'll take a break. So the retractors are the ones that are pulling that medial border in towards the spine, right? Keeping that arm from flinging out to the side when you throw a ball or when you do a push-up, that sort of thing. We're talking middle and lower trap and rhomboids. And rhomboids and, the lower trap have kind of a love-hate relationship. So they're friends when we're just retracting our scapula. But when we're working with elevation and depression, they are antagonists. So they don't always get along. Sometimes they disagree. But as long as it's, harmonious, we'll be all right. But you can see from that line of pull how they vary from elevation and depression. All right. So let's stop there. We're going to talk about the scapulothoracic rhythm when we come back. Spell binding. Okay, somebody help me remember to start the video when we are the recording when we come back, Mallory. That's your job. See, all I have to do is tell you to remind me, and then I think about it. Okay. So we're going to talk about that wonderful scapulothoracic coordinated motion that we all should love very well. We all should really appreciate our scapula. And speaking of appreciation, I wanted to do a shout out. I know we have some folks in our class who are vets, and we wanted to just do a shout out to you. Appreciate all that you've done, the sacrifices you've made for our country and for us. Okay, so the upward rotators, serratus anterior and upper and lower fibers of trap are the ones we're going to talk about the most. Middle trap does help, but it's more like a stabilizer, kind of just holds the scapula. It doesn't really help with the motion itself. So, so we're going to talk about upper, lower, and serratus. And they work together as a force couple. They have to be coordinated with their motion or things look hinky. And you can see it happen as they dynamically move through that. So as you elevate your arm, the serratus is going to activate concentrically, pull from the bottom, the inferior angle and the medial border, and then the upper trap is going to pull from the top of the scapula. So it's this sort of motion itself. And the deltoid is holding the arm up, so that's the job of the deltoid. But the upper trap is pulling at the spine of the scapula, the upper part of the superior angle, and then along the medial border is the lower trap, and the inferior angle direction is the serratus, although that's not the only insertion spot for it. If we have lost one of those motions, then we have lost our full ability to abduct our arm. So you won't be able to fully abduct to 180 degrees. So with the serratus in paralysis, and what nerve is that? The serratus nerve. What nerve palsy would that be if the serratus is no longer functioning? Long thoracic nerve. So if you've got a nerve palsy of the long thoracic nerve, and you have just your traps intact, you get middle deltoid and supraspinatus that actually cause some downward rotation of the scapula. The scapula is in an anteriorly tilted position because the serratus is not holding it against the thorax. And it also internally rotates. So that's that winging position that we talk about.
Can you explain the downward rotation?
Yeah, the middle delt and the supraspinatus are pulling on the arm.
Yeah.
And that weight of the arm is causing that downward rotation because there's nothing counteracting it.
Sure.
With the trap paralyzed, you again get weak and partial range of motion, although maybe not as, it's totally different. And I've got pictures. Without the trap, the scapula kind of rests in a downward rotated position. And the middle trap doesn't retract. So you lose that retraction or stabilization from the middle trap. So let's see if this is going to work. I never know if this is going to work or not. Well, this is promising. Oh, dang it. So much for promising. Let's get out of presentation mode. It's not very big, but.
Demonstration of scapular winging. Please start.
Yeah, you can't really see it. Sorry, guys. Wayne, can you kick the light, or somebody, can you kick the light off back there?
On
With
the
it?
right side. Go ahead. That's all that you can do. To ऊपर जाओ actually. With great difficulty, you can go to that much. Relax.
So the inferior angle of that scapula is not
Please
able
press
to
the wall.
move laterally.
Is the wall press test. Scapular winging. Okay. Now raise your hands forwards. Is there. You can see that there is an ocular scapular winging.
Yeah, I'd say. All right, so that is, I got another one. So this is trap weakness. It looks very different.
A 58-year-old man with previous surgery on the neck for thyroid cancer 3 years ago attains to the consultation.
You see the position that the scapula was already down. Oh, is that ugly?
We see the trapezius atrophy and the supraspinatus and infraspinatus fossa are clearly visible. Physical exam shows limitation to elevation of the right shoulder, elevating more than 90 degrees.
So the inferior angle goes out to the side because serratus is working. The traps is not
He has to take the shoulder
helping.
upwards in order to achieve some abduction.
You don't see the winging.
You can see clearly the rhomboid major, rhomboid minor, and the major scapular muscle.
So that rhomboid's doing a lot of the work. Oh, he is working hard too.
We see how the scapula remains attached to the rib cage when doing maneuvers that test the serratus anterior muscle. There is no rotator cuff injury. We consider the patient has an accessory spinal nerve injury.
Okay, so there's a significant difference. Thanks, Wayne. Significant difference in what it looks like. So when you're doing your evaluation, you can you should be able to pick up. When you guys are out there doing it, you should be able to pick up on what is the difference in the weakness. And that is complete palsy of both of those. So that is no muscle activation whatsoever. So if you have a weakness, you're going to see a less obvious, but still kind of the same movements available. And that is what I looked like when I tried to abduct my shoulder. It was really ugly. And I couldn't, I was trying with everything I had. And you just can't get that arm up there because you don't have the traps doing its job. All right. I should have told you that story before I did the midterm evaluation. You guys might have been nicer and had more sympathy for me. I don't know. Okay. Scapulohumeral rhythm is a combination of the glenohumeral joint and the scapulothoracic joint in abduction and flexion. There's basically a 2-to-1 ratio, with the glenohumeral joint providing 120 degrees and the scapula providing 60 degrees of upward rotation. So you get a full-on 180 degrees. Even if the scapula does not move, you're going to get 120 degrees. The gentleman that we just saw with the weakness of the traps, when he tried, he probably managed 120 degrees, but that was about it. Everything else after that was compensation from levators or whatever he happened to be using. The ultimate purpose of this is to direct the glenoid, direct the arm where we want it to go. So even as base as throwing a spear to kill a mammoth, right? It goes all the way back to Neanderthal days. This is not just something that we have developed because we want to throw a baseball, right? So in order to get our arm where we needed to get our arm to chuck a spear, we had to be able to coordinate these motions. So they're very fundamental. If my scapula doesn't agree, then all I got is sidearm, right? Which is not very effective. Although some people can really chuck a ball sidearm. The other thing it does is it maintains a length tension relationship for those multi-joint muscles that we use. So we don't want our deltoid to get too short to where it's actively insufficient and can't generate any more force. So by allowing our scapula to move, it helps with the length tension relationship for the deltoid, because that's that primary elevator of the glenohumeral joint. We just talked about in the last slide, it's increasing our ability to move our shoulders. So it's increasing the range of motion by having the coordination of these two joints. And we also provide stability for the arm to move, right? The scapula is not fixed to anything but muscles. So it takes that muscle dynamic stability. If you imagine the forces that are going through the scapula after somebody throws a baseball 95 miles an hour, right? You're flinging your arm 95 miles an hour, and to prevent that from flying off your body, those parascapular muscles, the scapular muscles that are holding that and securing that scapula, have to fire eccentrically to slow that scapula down just on the release. So it's amazing how you time and coordinate these things. And that's why the really good pitchers can throw as fast as they can, because they have practice and practice. Their body has sharpened its motor control of this activity. You ask them to throw a football, totally different monster, right? Totally different type of throw, and they aren't able to do it. So that's where that training and task-specific training comes into play. The other thing is it maintains the position of the glenoid fossa to improve the joint congruency as much as possible without allowing it to impinge and control some of the shearing forces that go on at the head of the humerus. So there's 6 kinematic principles of the shoulder complex. This is kind of summarizing the things that we care about with as far as the shoulder complex with shoulder abduction. You have 180 degrees of shoulder abduction that occurs from 120 degrees of glenohumeral joint abduction and 60 degrees of scapulothoracic upward rotation. That upward rotation of 60 degrees results from elevation of the sternoclavicular joint combined with upward rotation of the AC joint, or elevation at the AC joint. The orientation of the sternoclavicular joint and AC joints basically dictate where the scapula is going to end up. So restrictions in those joints can definitely impact the function of the scapula. There is some retraction of the clavicle at the sternoclavicular joint during abduction. We're going to look at that in a minute. It's kind of driven by ligaments. So this is the summary. So the clavicle up there, you can see that's looking up from below. You have about 20 degrees where it actually retracts. There's about 20 degrees of a posterior tilt of the scapula and a little bit of rotation, external rotation. And then if you look at the AC joint, you've got 25 degrees of elevation at the SC joint. And then this posterior rotation, we're going to look at that in just a second. But you've got 30 degrees of AC joint upward rotation. So all of those things, if you have full shoulder abduction, it's a minor miracle because all those things have to happen at the same time. You can't have a loss in one and have full motion. So number 4, the upwardly rotating scapula posteriorly tilts and has that little bit of maybe 5 degrees of external rotation. And when we start looking at things like shoulder movement, when we get to manual therapy, you have a bit of extension in your upper thoracic trunk. So as I abduct, I get a little bit of extension through my upper thoracic region. And that is another thing that we will look at if we need to work in that area, if there's some losses in thoracic extension. And that is fairly common because that forward head position, the seated position that is so common these days, really drives thoracic flexion. So you can have a loss of that extension that impacts your ability to really elevate your arm the whole way. So the scapula is maintained on the thorax, orienting the glenoid fossa where we need it to. And it also helps to move that coracoid arch away from the elevating glenoid, the head of the humerus, where those other structures get impacted. And then that clavicle posteriorly rotating 20 to 35 degrees, that's a pretty significant rotation that occurs through your clavicle. And then you've got a little bit of external rotation at the glenohumeral joint as well. So all those motions have to happen. So this is how that clavicle does that posterior rotation. The clavicle is kind of shaped like a crank, right? It's not like a PVC pipe. It actually has a little bit of a bend in it. So as the when the serratus kicks in and that inferior angle moves away from the trunk, it actually tightens up the corticoclavicular ligament. And that insertion on the clavicle cranks the clavicle back into posterior rotation. There are other muscles obviously attached to the clavicle that have an impact on that as well. But the most important thing is just that, that posterior rotation of the clavicle. If that doesn't happen, then you don't get full range of motion. So it's kind of a passive thing. It's not really a muscular motion that occurs at the clavicle. It's pulled along by the ligament. And this is just kind of a diagram of scapular winging. I put this in before the videos. You guys don't have the videos, but I'll post those on Canvas for you if you want them. But this is that scapular winging. So the serratus does not hold that inferior angle down. So when you push on the arm, the deltoid pulls the scapula along and causes that winging motion. All right, so the rotator cuff muscles, these are good guys to have. You see a lot of people with shoulder problems with rotator cuff muscle weakness or deficits or injury and that sort of thing. They're relatively small, but they have a big job. So we're talking about the sits muscles. You guys know those. And their orientation. So again, they pretty much surround the glenohumeral head, except in those two areas that I told you about. And coordinated with the deltoid, this is how they function in a forced couple. The supraspinatus compresses, the subscap infraspinatus teres minor, hold the head of the humerus in the joint as the deltoid elevates the arm. That is their primary job. The subscap and infraspinatus also are internal and external rotators. So they go on either side of the glenoid. So they offer a compressive force as well. All right, so let's look at muscles that adduct and extend the glenohumeral joint. Bunches of them. Posterior delt, latissimus dorsi, and teres major. Pretty much whatever latissimus dorsi does, teres major does as well. It's kind of like, you know, Tweedledee and Tweedledum. The long head of tricep and the sternocostal head of pec major all work to adduct and extend the glenohumeral joint. So this is that, you know, that motion where you're pulling this way, where you're pulling it down, elbow down towards your side. The diagram there shows rhomboid kicking in. That rhomboids are also helping stabilize the scapula because those muscles attach to the scapula. And so we have to have a firm scapula for them to pull from. So that job is helped out by the rhomboids. Internal rotator muscles. The main ones are your rotator cuff or the main ones are not. Main rotator cuff muscle is the subscapularis. There we go. I knew I was trying to dig that one out of something. But then you've got pec major, big honking muscle. Latissimus dorsi, big honking muscle, with his little buddy teres major. And anterior delt, big honking muscle. So internal rotators produce 40 to 70% more torque than the external rotators. They're big honking muscles. So when you go to throw a ball at 95 miles an hour, your internal rotators are helping to generate that force, but then you've got your small little external rotators that have to control that force, slow it down so that you don't end up damaging your shoulder. And that job is left to these little guys, infraspinatus, teres minor, and posterior delt. So it is as important to have good eccentric control of your external rotators as it is power generation for your internal rotators when you throw, or you're going to end up with injuries and all that kind of stuff. These external rotators are all between the scapula and the humerus. Right? They don't have attachments onto the rib cage or other places like the internal rotators do. So they very much depend on the scapular stabilizing muscles to do their job. All right. Okay, so here's a case. We're going to talk about this one. Shoulder impingement, I said before, is a common problem that we treat in the clinic. Of all the shoulder problems, this is probably the most common. Typically a result of the humeral head not being in the right position during motions of the shoulder, typically elevation. And so it encroaches on the coracoacromial arch and decreases the subacromial space. So with your current knowledge of your shoulder mechanics, what factors could contribute to an impingement? So just take a couple minutes. I'm going to have you write down a couple thoughts, what you think might be contributing to a shoulder impingement. Think about it as what things can I impact or address as a therapist to improve that? Active and passive. right. Somebody have a suggestion for me?
There's no inferior glide.
Okay, so a reduced inferior glide of the head of humerus. Yep, so it's sitting too high in the joint. Okay, anybody else? Well, I know because there are like 50,000 of them.
Lacking the rolling portion of the knee.
So again, like a capsular restriction where it's got maybe adhesions in it.
Or even like a supraspinatus issue.
Yep. Okay. Another one? Yep.
You have like a swollen bursa.
Perfect. Yeah. So you've got inflammation of one of the structures that's in that subacromial space. So we'll say an inflamed, I'll put bursa, but that could be an inflamed tendon. Yep. Any specific muscle weakness you might be wanting to address? What helps to center the head of that humerus in the joint? Rotator cuff muscles? Yep. Which ones? Supraspinatus? Yeah, the three that help with that line of pull into the joint are important. Supraspinatus is frequently affected because it's impinged. So it's not, I mean, it can be a weak one, but it doesn't really affect the mechanics as much as the other three. So, supraspinatus is always one that we have to address because it's usually angry. It usually has some swelling. So infra, subscap, oops, and teres minor. Anybody else? How about things that might affect the orientation of the glenoid and the scapula? Right, yeah. So if the scapula is held in a downwardly rotated position or not allowed to elevate, so again, maybe there's some, this is weakness, maybe there's some weakness in the serratus, right? Or maybe there's weakness in the traps, not allowing that motion to move, the coordinated motion of the scapula through that motion. Think about a posture, chronic posture that may impact the ability of the scapula to move through its full available motion.
Forward head posture.
Yeah, right. So forward head posture. So that forward head, protracted scapula, this kind of posture, right? You can see that in people. So we're gonna say a forward head. Protracted scapula position. And muscles that would be tight that would do this. What muscles would you anticipate being very tight, keeping the scapula, let's look at the scapular ones, in that position? Pec minor. Oh my gosh, yeah. So you see somebody come in your clinic and they've got one of these kind of postures. Their pec minor, I guarantee if you lie them flat on their back and you go like this, their scapula doesn't touch the table, right? So that pec minor, really, really tight. So as you elevate your arm into abduction, that pec minor pulls your scapula forward, jams up all sorts of crap, right? You can't externally rotate, you can't extend through your trunk. So you end up with a lot of compression just from postural. And gosh, we can make a huge impact on posture, right? Anybody else? I think that's pretty much all. So the shoulder capsule too tight, limiting arthrokinematic motion. So that's what we started right off with, right? So you can't glide like you need to. The capsule has adhesions from damage or something like that. And so you just can't glide one bone on the other. How about a loose capsule then? Right? So you've got ligaments that are supposed to restrain motion in certain ways. The middle, thinking primarily of the middle and inferior glenohumeral ligaments, or the capsule itself is just sloppy. You know, so it could be somebody who just has overstretched and overstretched. If you look at pictures, right, they can get like this much external rotation of their shoulder. So they've got a lot of laxity in the anterior capsule of their shoulder. So that can be a problem. So how would we address a capsule that's too loose? What can we do to support that? Anytime ligaments are too lax or you have some instability from lax ligaments, that's passive support. So what can we?
Strengthening the rotator cuff muscles.
Right. So active strengthening. So get some active support from the muscles surrounding that joint. That's in any situation. So the rotator cuff muscles are weakened or they're just fatigued. So a lot of times this happens when you first start practice. And if you haven't been training in the off season, the rotator cuff muscles only make it halfway through practice and then they start getting fatigued and then they're allowing all sorts of extraneous motion to occur, the glenoid inside the joint, and it allows it to jam up into those, the acromial arch. You might have rotator cuff muscles that are overused. So again, we're talking about those poor little external rotators slowing the arm down after ballistic movements. So they just may be overused, tired, stretched out. The postural alignment thing is huge. Anytime I'm working with somebody with a rotator cuff problem, impingement, whatever, posture is always in the treatment plan. Always, always, always. And then remember that coordination, everything needs to be coordinated. So perhaps there is some communication that's not happening between the stabilizing muscles. It's not allowing the coordination of the scapulothoracic joint as it moves through its rhythm. So a lot of things to look at. So we can't just look at, you know, you get a script for somebody and they've got a rotator cuff weakness. We can't just look at rotator cuff muscles or if they've got an impingement of their shoulder. You've got to take in all of those factors that can have some contribution. The other thing I didn't mention is, what if the AC joint is restricted and not allowing enough upward rotation, so it's causing some jamming at the top of the motion. So those things need to be looked at too. Okay, so we've got Mr. Green coming to see you for left shoulder pain. He reports an onset of pain about 3 weeks ago after painting a house. He reports pain as being sharp whenever he tries to reach overhead. There's no pain at rest, and he doesn't have any previous injury to the shoulder that he can recall. Pain gets worse as he goes through his day. He can't lay on that left side because it's too painful. He is right-hand dominant. So that's one thing. And his hobbies include inline skating, tennis, and working out. So you do your evaluation. So let's do this. Let's talk about, so his left shoulder is what's hurting him, but he's right-hand dominant. And the activity that he tells you that he did was painting a house. So right off the bat, you're thinking overuse, right? Probably overuse. It's his non-dominant arm. He's not used to using it for this kind of activity. And then here he is, you know, painting a house for however long, a week or 2 weeks or something like that. So right off the bat, your brain is starting to think, could be an overuse situation. He doesn't have any trauma to remember that he's remembers. So that's kind of what you're looking at. Okay, so this is your objective data from your evaluation. Left shoulder, active range of motion is 120 degrees. Abduction is 85 degrees. Oh, he stops because of pain. Oh, kills him. Passive range of motion is within functional limits, though. So when you have him lie down on a table and you move his shoulder through that range of motion, you're able to get it, you know, pretty close to 160, 180 functional motion without too much difficulty. So what is that telling you right there? Active motion is limited, passive motion is fine. So what of these things can we take off the table? What do we know it's not? Right. His capsule's fine. There's no problem with the gliding of the capsule because his passive range of motion is fairly normal. So we can take that off. Okay, so scapular elevation. He does scapular elevation as a substitute for glenohumeral motion. So he's doing this, and then it just hurts too much for him to raise it. He doesn't do it. So he's trying, but he's doing this motion, kind of like you saw in that video. His the flexors and abductors are strong, but they're painful. So when you hold it out there and you give him some resistance, you can probably get to 4+, but he stops because of the pain at the final end of that. So what does that tell you? Strong and painful. His flexors and his abductors.
I think there would be some swelling or inflammation that's causing the nerves to fire off.
Yeah.
And
So
generate pain.
so you're zipping ahead, right? So we know that it's the muscles, not the main flexors and abductors. So we're not really doing the rotators, right? We don't know about the rotators yet. But his deltoid is fine. Upper trap's fine. The strength is fine. So he probably doesn't have a problem with, you know, like a palsy.